everyone. I'm Annalise Riles. I'm the Executive Director of the Northwestern Buffett Institute for Global Affairs. And thank you for taking time to join us today in this next installment of our weekly webinar series focusing on the global dimensions and implications of COVID-19. As we all know too well by now, COVID-19 is a paradigmatically global phenomenon, and as such, it confounds local and national public health frameworks and challenges us to better address the stark implications of our global interconnection by devising more collaborative global policy approaches. So today we are absolutely delighted to have with us the Executive Director of the Institute for Global Health at Northwestern University, Dr. Rob Murphy, who will speak to us today about these issues, addressing how to blunt the impact of this global pandemic most effectively and how we might learn from this experience to better prepare for future global pandemics. Rob is Professor of Infectious Disease at Northwestern's Feinberg School of Medicine, where he studies viral infections. His research focuses on developing new antiretroviral drugs and vaccines for HIV and viral hepatitis, and scaling up therapy for AIDS, tuberculosis, and malaria, especially in sub-Saharan Africa. He has extensive experience with the HIV crisis, and you may have seen him throughout this COVID crisis every morning where he provides commentary on WGN here in Chicago. So thank you, Rob, so much for taking time out of your incredibly busy schedule right now, seeing patients and providing your expertise to our community. We're delighted you're here and look forward to your thoughts. Over to you.
Thank you very much, and thank you for inviting me. Thank you for all participating in this presentation. So I'm going to talk for the first 30 minutes of this, and then we're going to open it up to questions from people because I know people will have a lot of questions. So I will outline a little bit about the virology, what we know about coronavirus 19, a little on the epidemiology, some of the interventions, the impact it's having on the healthcare systems, and this is a global perspective also, and how we can design the optimal global health response for better preparation in the future. So, human coronaviruses, they've been around for a long time. They're listed up here. 7 of them these are the 7 that can affect humans. There are many others that affect just animals, and it's likely that an animal one did jump into the humans at some point. The first 4 that you see up there are typical coronaviruses that cause the common cold. About maybe 15% of common colds are those. They have really no significant pathology associated with them. They're minor in nature, rarely cause anything severe. Then, of course, along with SARS, severe acute respiratory syndrome. This was a little bit different, caused pneumonia, ended up with a 10% mortality rate. But that burned out after only about 10,000 patients got infected. Then came the Middle East Respiratory Syndrome, or MERS. This is still exists today, but it's confined primarily to the Middle East, only a few thousand patients. However, the mortality rate is 30% with MERS. So we go from 0% to 10% to 30%, and now we have SARS-CoV-2. So this is the virus that's causing COVID. COVID-19 is the actual disease, and the virus is called SARS-CoV-2. You hear the terms talked about interchangeably, but they're slightly different. So we'll talk about that. Now, there's a lot of deadly viruses out there. SARS-CoV-2 is not the only one. Ebola. I think a lot of people are familiar with that. But we also have Hanta, Lassa, rabies, smallpox, dengue, and of course influenza, which is commonly compared with coronavirus. There have been lots of epidemics listed on the right side of this slide. HIV, of course, is the most recent one until now. But there was the Hong Kong flu, killed 1 million people in 68, the Asian flu in 56, 2 million. Inappropriately named Spanish flu, 20 to 50 million people after World War I. Bacterial infection, cholera, 800,000 in 1910. The Russian flu in 1889. You can read there, it goes back, the first recorded one was in 165 AD. So epidemics have been around for a long time, and we're in a new one. So here's the list of the coronavirus epidemics, starting in 2003 with SARS, then MERS, and MERS came back a couple of times, including one time to South Korea. And this is important because the South Koreans are behaving differently from most of the other countries, as I'm going to show you. And now, of course, we have our own epidemic. Okay, so what happens to a person who gets infected? Well, it's pretty vague symptoms and very typical for influenza or any other respiratory tract infection. The hallmark, though, is fever. Virtually everybody has a fever. But you can see fatigue, dry cough, anorexia, myalgias, shortness of breath, and sputum production are there. And then most recently, an unusual symptom has been popping up, and that's loss of smell. We're not really sure how that fits in, but that may be one of the first symptoms that appears in COVID-19. Here's the global statistics as of this morning. So, this is a disease. This is the Johns Hopkins website here. They're keeping it's a beautifully kept up to date, country by country and state by state. The global load now is 392,000 with 17,000 deaths. China's still in the lead, but Italy and the United States coming up close. You can see Italy's got 64,000. The U.S. is now up to 46,450 cases. Spain not far behind, Germany, Iran having a big problem, France, and then South Korea, 9,000. I'll show you the curve on South Korea in a second because it's an important lesson that we can learn. You can notice that the Southern Hemisphere is not as impacted as the Northern Hemisphere. However, that's slowly starting to change, particularly in South Africa. Now they're reporting quite a few cases. Now, this graph goes up to the first week of March of this year, and you can see that when this thing takes off, the curves are very sharp. China is not on here because their curve was a little bit before, but to focus on the kind of second wave of infections. So South Korea, Italy, and Iran, the rest of us, the United States, down at the bottom there. And you can see how steep those curves are. Now, look at the last 3 weeks. If you take the last 3 weeks, the USA has jumped way up there, Spain, Germany, and Italy still increasing significantly. But South Korea is not. South Korea has basically leveled off. And I'll talk a little bit more about why I think that's happening in a few minutes. So this is the pattern. What we want to do is we want to be like South Korea. We want that, this is what they call flattening this curve. We want this curve to go down. Now, the hallmark of the South Korean model is very different from what we're doing here. They had, remember, they had the MERS, they had a little mini MERS epidemic, and they had SARS epidemic. They kind of got all set up to look out for the next coronavirus. And their philosophy was test, test, test. And you can see here on the left are the number of tests performed by country, and on the right, it's the number of tests performed per million people. So South Korea is in the blue on the left side anyway. And they have definitely done the most tests of anybody. The United States is down to about 100,000 tests. If you look at tests per million, the United States barely registers on this graph. We are way, way, way behind in the testing. South Korea is in second place, only beaten out by the UAE, which doesn't actually have a big population, but they test like mad. But the South Koreans are really very much into testing. Let's look back at the U.S. statistics. New York is now the epicenter of the entire epidemic in the world. 23,000 cases. They've converted the Javits Center into an emergency hospital. I mean, things are really going pretty crazy over there. Followed by New Jersey, 2,800, Washington State, California, Michigan, Florida, and Illinois at 1,285 with 12 deaths, what we have. Now, take a look at the outcomes. Last week, the MMWR, the weekly report from the Centers for Disease Control, reported on the first 4,226 patients as to their outcomes. You can see, looking at fatality, and I think everyone has already knows this, that the older the people are, the more likely they are to die. Of course, the more likely they are to die with any illness because they are old and frail and have underlying diseases. But if you're 85 or older, the fatality rate is between 10 and 27%. 65 to 84, it's 3 to 11. 55 to 64 is 1 to 3, and then it drops down significantly after that. So if you're just looking at death, it's really older age and underlying conditions. But the scary, an as scary part is number of hospitalizations and ICU admissions, because this is going to stress the hospital system as much as fatality. Now, most people are not dying at home; they're coming in the hospital, so they're cared for in the hospital, and then they die. But look at the number of hospitalizations. Only 9% of the hospitalizations are in people over 85 years of age, and 26% 65 to 84. There's plenty of people being hospitalized in every one of the age brackets except for the under 20. Children are relatively protected, although there was a case from Panama on a 13-year-old who died recently. If you look at the ICU admission rate, we have a very limited supply of ICU beds. You can see that the ICU beds are not taken up by the greater than 85 crowd. They're taken up by the 65 to 84, 55 to 64, and those two groups from 45 to 64 is 36%. And even 12% in 20 to 44 years of age, ICU admissions. These are dramatic numbers because, remember, the other diseases in the world that we take care of have not gone away. So everything that you see here with coronavirus is on top of what's going on a normal day in a hospital or ICU. So if you take a cut at 65 years of age, you find that 31% of all the coronavirus cases are in this group, 53% of the ICU admissions, and 80% of the deaths. And you can see the breakdown there. And so that's why this 65 years of age and older group is being advised really to shelter in place and not go out and really avoid any kind of contact. To put it all together in a slightly different format, it might be easier to digest. You can see in the light blue, hospitalizations, ICU admissions in the medium blue, and deaths in the dark blue. I think it's easier to visualize it here. This is a lot of hospitalizations. This is going to, swamp. Italy is already having a major crisis here. In China, they built, 1,000-bed hospitals in 10 days. And we're thinking about converting hotels into hospitals. It's because of this figure here. Now, what can we do? This is important because the current interventional approach in the United States is going through some changes. The United States is not set up with a strong central public health department or organization. Most of the public health interventions are relegated to the states, and the CDC just gives guidance to the states, and the states can do it or not do it. So we can do nothing. We can wait for a vaccine, wait for a new treatment. This is a philosophy that has a lot of risk to it, as I'm going to show you some other statistics in a second. But this is a philosophy that is gaining traction at the present time. Maybe we'll talk about that in the question session. We can do case isolation with household quarantines, close schools, close universities. We've already done that in many cases. We can add social distancing to that. And if nothing works and the disease still is out of control, the government actually has the authority for mandatory quarantine, government takeover, and martial law. So this is the whole direction that this thing can go. So social distancing. I had really never heard the term used very much before about any kind of disease, but actually it goes back to the Spanish flu in 1918, where Philadelphia and St. Louis took two different approaches to the flu epidemic back then. Philadelphia basically did nothing until it was too late. St. Louis closed bars and banned gatherings early on in the epidemic there. And you can see it's quite clear that people in St. Louis did much better than the people in Philadelphia. By the time the Philadelphia people caught on, they had already had quite a few deaths. This is what social distancing looks like in New York City. This is Times Square. I think this picture is from yesterday. And, you know, on a weekend, Times Square, normally there's a whole pile of people in here, and there's basically nobody there. That's social distancing. That's what we're trying to do now. Now, last week, there was the article from the group in Imperial College London that we're doing the whole transmission and dynamics of the infection based on the modeling that they've done. They have several different models. If you can see it here, this is actually really not, this is a dynamic graph, a dynamic figure, excuse me. All the points on the bottom here can be adjusted individually. You can adjust population, you can adjust death rate, you can adjust any of that. And this curve will actually change as you change the parameters down there. So however good your data is, you can put it into this model, and you get results like you see above here. Here it's this is playing around with the numbers, but perhaps we're talking about maybe 10 million deaths in the way the model is prepared here. Let's look at another thing that I think is maybe a little bit easier to digest. Let's just look at the infection rate and the fatality rate. Now, we think that coronavirus is more lethal than the flu. The flu has a mortality rate of about 0.1%. And in Italy, it's between 2 and 4%. China was 2%. We think, though, that the rate in the United States is about 0.5%. Now, if the infection rate in the country, and you go from the top, from left to right, and then bottom left to right, if it's 10%, that's the top left here. You can see the coronavirus infection death numbers is 165,000. It would become, if we get up to 10% of the population being infected, 165,000 patients will die. So this is about twice as much as a bad flu year. Now, if it goes up to 20%, 30%, on the bottom 40, 50, and 60%, it changes quite dramatically. And so when you hear the argument to push back on these intervention efforts, the trade-off is in the infection rate in the population. So if you stop, social distancing or open the schools up too early or whatever, you push this infection rate higher, and if you do nothing, it's estimated you're going to infect about half of the population, so the 50 or 60% rates that you see at the bottom right of this, which would make coronavirus the leading cause of death in the United States, with approximately just under 1 million deaths per year. So that's where we can go if we do nothing. Now, what about the other crisis here that we have to discuss is the hospital system capacity. Now remember, our hospitals are designed to run at a very high occupancy. There's very little leeway in the hospital system in the United States. All this morbidity gets thrown on top of everything else that's already going on. So that includes hospitalized patients in the light blue here and ICU patients in the darker blue. Now, the dashed red line are the number of ICU beds that we have right now. And so you can see that there's very little give and take in the ICU bed population. We just don't have the beds. It's not an elastic situation. And then this translates to who's going to be in an ICU? Probably somebody that needs a ventilator. So the same thing is true for the equipment that is needed to care for a person in an ICU. And on a more pedestrian level, people in ICUs and people in hospital you've got an infectious respiratory condition, we need masks, we need gowns, we need gloves, we need all sorts of stuff. And we don't even have the capacity we don't have the capacity today to even provide the hospitals with the amount of protective, personal protective equipment that is necessary. Let's look at the American Hospital Association statistics of what is going on in the United States. We can see we've got a little over 6,000 hospitals, almost 1 million hospital beds. We admit over 36 million people per year. We've got 46,800 or so med-surg ICU beds, another 14,000 cardiac beds, another 7,000 in community hospitals. We have approximately 160,000 ventilators. We've got in our national strategic supply an additional 12,000. Only half of these are even made in the United States, and they're expensive. They're $25,000 at the end, at a minimum. So what is needed? Actually needed right now are hospital beds, ICU beds, actually number of hospitals, ventilators, personal protective equipment. We don't even have enough swabs, cotton sterile swabs, to do the test for coronavirus. So we have more test kits, but we need more swabs. All that stuff is lacking actually as we speak. Now, how can we, instead of just adding more supply, what can we do to decrease the ICU bed needs, and how does social distancing fit into this picture? So you can see here, if you do nothing, you have the black curve. You have this big peak, you overload the system, the hospitals will basically implode. You're going to infect a lot of healthcare workers, and they're going to clog up the entire system so that if you happen to have a heart attack or something else in the interim when all this is going on, you're not going to receive the care that you would receive if the hospital was not stressed out dealing with all the coronavirus cases. So the mortality rate overall from coronavirus is one thing, but from everything else is also going to increase. Now, if you do case isolation, if you do household quarantine, if you close all the schools, if you do everything, you can see that that curve goes down. And if you're doing everything, you're in the blue curve, kind of at the bottom of this graph here. So we have to do something like that to blunt the impact we're having on the system. In this group here, also, just closing the schools and doing some general isolation stuff actually just in some cases actually will just push the whole curve over to the right. And just closing schools is not enough. As you see in the green, you've got to continue with the case isolation and household quarantine and the generalized social distancing to really have some kind of an impact. So this is a controversial graph from that Imperial College paper that came out last week because the modeling is actually for the US here, getting infected are peaking right about now, but the damage is going to be out here later in the year. Now, what can we do? We can actually, there are laws on the books today, the Defense Production Act of 1950 actually, where the United States government is actually allowed to take over industries during war periods or time of crisis, if we consider this a time of crisis, and basically direct the companies to make more ventilators, make more personal protective equipment, make more reagents, more testing facilities or whatever, quarantine facilities, requisition hotels and arenas and sports facilities. Now, obviously, this is not popular in certain groups, and maybe it's an extreme measure, but from what's coming up, I don't really see any way that how this could not be avoided. The picture on the left, it's a very famous picture. It's Sewell Avery in Chicago, the head CEO of Montgomery Ward's, big department store at the time during World War II. He didn't want to cooperate with FDR, and he wouldn't change their supply chain to support the military, and the people surrounding him are not his fans. Those are military police arresting him, taking him out of his office, actually in his chair to jail. So that is actually one thing that can be done. This is the Defense Production Act, and some people are calling for it to take place now. We have companies that are making masks, ventilators, and whatever, and selling them to Japan, Taiwan, whatever. And here, the governors are scrambling, competing with each other to buy all that equipment and supplies, and they can't get it. So what has this done? Of course, the markets are in free fall at the present moment. The companies, the stock market capitalization has radically altered. The Trump bump is completely gone. Now we're coasting downhill. The media company Zoom, the distance media, they boomed, of course, but Uber, the hotels, the airlines, the shipping industry have all lost very significant amounts of wealth because of this whole epidemic. It's having a major financial impact, and we're going into a recession. So I would just like to close with a couple of things so we can open it up for questions. Everything that has to be done is completely doable. If we made everybody stay in their house for the next month, the whole thing would go away. So social distancing as much as possible is mandatory, basically. Schools and universities have to remain closed. This is going to require some kind of support for the unemployed and those without health insurance, because there's no point having uninsured people run around spreading the virus because they can't get treatment or whatever. There's got to be some support for them and support for people who are going to need food and housing support for the next couple of months. I mentioned the South Koreans have a different model. Their model is just to ramp up the testing. They're not so much into the other prevention, other interventions. So they test now 15,000 people per day at 43 drive-through facilities plus clinics throughout the country. And this has been going on for a while. And what they do is then when they get those people tested and they're positive, they isolate them and their contacts for the 14 days. Through the phone numbers and the social media accounts, they actually can map out where these sort of hotspots are occurring in the country, and that's how they're controlling the epidemic in that country. And that's why the only country that has really flattened out the curve early on. So if we were to take at least the testing component of that, that would mean we would be testing 4,000 people a day in Illinois. I can tell you we are not testing 4,000 people a day in Illinois, and 100,000 people per day in the United States, and we are not doing it. The reason why the testing is so important, besides just identifying all those obvious ones that have COVID-19, is that it turns out there are a lot more people than we thought that have absolutely no symptoms, but are infectious and are spreading the disease. And the only way you're going to do that is with mass screening. So mass screening is essential. If we don't do mass screening, I think it's really nothing's going to work that well. We do have to ramp up the diagnostics and the supplies and the hospital capacity as quickly as possible. It's all happening as we speak. And if we have to have that law put in place, so be it. Public health policies to be vigilantly enforced, and massive vaccine development initiatives and antiviral drug development programs are essential. Now, this is the silver lining in this whole thing. There are some 3 dozen vaccine candidates in development out there. Some of them have actually initiated clinical trials. So that's good. There are 80 antiviral drugs either already in existence or in some stage of development ongoing. The virus is a relatively simple virus, and there are well-known targets, and so drug targets, and so drugs can be developed for this thing. One of the problems in this whole process is that by the time these things get developed, the epidemic may be over, maybe too late. But, some of them are further along than we imagine, and especially if we don't control the thing and it dribbles out for a year or so, it's very likely that the vaccine or one of the drugs will come out in the interim. So the final take home is the more forceful we act now, the shorter the problem will be. And that with the example of South Korea, but also I didn't have time to really go over it, but Japan, Hong Kong, Taiwan, Singapore, those countries have been able to really suppress the infection rate to a dull roar, and that should be the goal that we have right now in this country and worldwide. So I'll end my comments there, right at 30 minutes, and we'll open up for questions.
Great. Thank you so much. Can you hear me? Yeah? Okay. Thanks so much, Rob. That was fantastic. Really helpful. We have tons of questions, and maybe I'll start right where you ended with Japan. So one of our participants asked, why has the death rate been so much lower in Japan than, say, in Italy, where there's also high densities of population and lots of older people? What are hospitals in Japan doing to keep from being overwhelmed?
That's a really good question. I can't really answer it. The thing in Italy is it's really a combination of the lack of central control in the whole intervention efforts. The Japanese are more attuned to taking central direction and everyone kind of operating on the same page. Italy has really demonstrated the opposite of that. So you have shelter-in-place rules and quarantines going on, and then a group will have a giant dinner together celebrating that they had a decrease in the number of infections, and then the whole thing starts all over again. It's really quite the data are really quite stunning. Now, to their credit, I think they finally put some teeth in the rules, and it's not the whole country, but if the whole country doesn't act the same, it's not going to work. They have had over the last 3 days a decrease in the number of deaths per day, so maybe it's turning around there. So I don't know if that answered your question, but
yeah, great. Thank you. Another question has come up multiple times is, assuming we follow the best practices of social distancing, how long would this be necessary in order to get us through the epidemic?
That's the question of the hour. It's definitely not 15 days. That's for sure. You can go back to some of those models in that Imperial College paper, and you can play around with the numbers. The stricter you are, the shorter that whole bump, that increase will occur. So I would think, well, it depends really if this new policy of stopping the interventions, if we stop most of the interventions or leave it up just to the states, I think we're in a lot of trouble, and this thing's going to last for 12 to 24 months. If we all get on the same page, I think we could start seeing a decline in the early to middle summer.
So actually, that raises an issue. I guess you're suggesting, comparing Italy and Japan, also that by getting on the same page, you mean at the national level and not at the state level. Is that right? Yeah, right. At the national level. I mean, you can't have, one with open borders of the states. We have open borders between the states. You can't have one state having a lockdown and another state not locking down, and people traveling back and forth and whatever. That's the problem. We really do not have a central. We don't have a central plan. There is nobody leading this charge. You have I got asked the same question this morning.
Yeah, and you know, the people that are making some very fundamental public health decisions are not public health experts. Without mentioning who they are, I can say people that have a bachelor's degree in finance. There's one with an MBA. There's one that actually caused an HIV epidemic in a neighboring state. You know, we have these people making very significant public health decisions and ignoring our own public health experts. If that continues, we're in big trouble.
Wow. Okay, another question that's come up a few times is, why are there so many shortages of test kits and swabs in this country compared to, say, South Korea? What would it take for the U.S. to set up testing on the scale of South Korea?
Okay, we have the capacity. The capacity, the potential exists. We've got Abbott Labs right here, 40 miles away. They could probably test the whole country. But they would have to put all or a huge number of resources just into the testing kits and forget about everything else or many other things. They'd have to prioritize doing that. And, they are cranking out tests. They came online, actually Abbott came online, I think a week ago, to their credit, thank you. But it's not enough. It's definitely just not enough. The Koreans got prepared for this because they got scared during the SARS and the MERS epidemic. They also have a very healthy biotech industry. It's a very top-down government, and the industry and the government all, they're much better coordinated than they are here. And they just cranked out all those tests. And this is compounded by the fact that at the beginning of this thing, we opted a conscientious decision not to import the WHO-approved tests from Asia and Europe. And we insisted on making our own tests, the CDC. And the test that was made, which took a couple weeks, was sent to the States, and it turned out it didn't work. So all those kits came back, and then they had to sort of redo the whole thing. So we wasted an entire month. And as you can see, the doubling rate of this infection, in some places it's every 3 days, and some it's every 7. That month was really critical, and we haven't been able to catch up yet. There's no one, basically, it's a war without a general. We need all these pieces, everything to be kind of working together. The governors don't have the ability really to marshal the industrial forces that a president would have, and so the governors have their hands basically tied. So they're out there just competing with each other. It's just not as simple as just picking up the phone and ordering. It doesn't. That's how it works.
So as Rob, as an expert in infectious diseases in sub-Saharan Africa, yeah. One of our viewers has asked about what you predict about the impact of COVID on countries with less prepared health systems, such as in sub-Saharan Africa or India. What are you expecting that we will see there?
Well, it depends which route they take. I think in the news today, President or Prime Minister Modi from India just told everybody they can't leave their house for 3 weeks. Somebody correct me if I'm wrong. I think I saw that flash by. They're starting to put into place some pretty strict regulations in South Africa very recently. And the countries are coming along. The ones that do that will probably do better than the ones that don't do that.
How many waves does the modeling predict that we can expect of this disease, especially as it moves around the world and people continue to circulate?
The Chinese are already, they have most of the country now is pretty stable, and they are removing some of the restrictions in Wuhan and the surrounding province. And the outbreaks they're having are from people coming back into China from Europe, Africa, and other places, where they're bringing in like a new batch of infection. So we have to be vigilant with this, because it's the moving around of people that is reigniting the fire.
So do you support border controls, Rob?
Yes. I mean, until we can have it would be nice if we had the ability to do testing at the airport other than just taking a temperature. That's not good enough. So if we, had screening, rapid screening tests, that would be great. Probably unlikely with the huge numbers that we're talking about. But, it's really about testing. So some of the countries now, Israel, Botswana, New Zealand, have now quarantining everybody for 14 days coming in the country, no matter who they are. So that's another way to look at it.
What is your view, likewise, of you mentioned vaccines and the silver lining of all these vaccines? What's your view of about fast tracking vaccines?
Yeah, I think it's already being fast tracked. The vaccines have already gone into humans, several of them, but that's just phase one. Those are the uninfected people, just to see about safety, antibody production, after the injection. So they're definitely being fast tracked. With the small molecules, what we're finding is, this is an RNA virus, and there are many drugs out there for other related but different viruses. And so we're looking at using some of those drugs to treat this. So some of them, you've heard of the malaria drugs, chloroquine and hydrochloroquine that, may have some activity. But none of those have been, although they exist out there, none of them have been proven to actually be effective. We have to be careful, because it was originally, we thought that ritonavir, the HIV drug, was effective, and people started using it. They even ramped up production of it because it's actually not used very much anymore. And in the one controlled study that was done, it did nothing. With the chloroquine, there was a slew of reports this morning on toxicity to chloroquine. It has also retinal toxicity and other toxicities. Somebody died taking it. There's all sorts of things. The Chinese actually have it as a recommended treatment, and this is based on really very, very little evidence that it's going to work. So it's really got to be studied.
So another question is, should we expect that this virus is going to mutate into another, COVID-20 or something? By the time we get a vaccine, there'll be another version of this?
That's a good question. The viruses mutate all the time, but they usually don't mutate that much that makes them either more pathogenic or less pathogenic, although that can obviously happen. But they mutate to the point where if you study them, you can actually kind of find out where they came from. Like the one, outside of China versus inside of China, or one part of China versus another, the Italian one or whatever, you can actually kind of figure out, you can map it. That's more likely what's going to happen. I think, there's so many other coronaviruses and other viruses out there, these emerging infectious diseases, that most likely that coronavirus will treat it, develop a vaccine or whatever, and it'll burn out or something, it'll go away. But then another whole kind of different virus will happen. Keep in mind, the SARS-CoV-2, the COVID virus, is 60 to 70% genetically related to SARS. So it's fairly close. So it could be something that's much more, another 30% different. I mean, imagine if SARS-CoV-2 had a 25% mortality rate. I mean, already MERS was 30%. So It's amazing what could happen, but we've got to be really prepared for that. And we have to invest in all these emerging infectious diseases. They're not going away.
So we have a couple of questions about data. So one viewer wants to know, how are cases tracked? To what extent do providers like Northwestern Memorial have to report results of tests to? And then also, how should they be tracked? How transparent should authorities be about specific information like where people live, residences, ages? Obviously, different countries have taken different approaches. South Korea has mobile apps where they're tracking people. The Israelis have a different approach. What do you think about that?
Yeah, no, I mean, we're beyond the tracking part. It's too far gone already. We have to think of something different. I mean, we can take a positive person and isolate, make them self-quarantine, and everybody in their family and close contacts self-quarantine. And the Department of Health, Illinois has the city of Chicago, the Cook County, and the state all kind of play a different role here. And they will at least do they make some attempt to get that message across. But that's about it. It's too far gone.
Okay, and could you say something about where the data that you've shown today comes from? How do hospitals report? How do you, as a researcher, get the data?
So here, everything gets reported to the Illinois Department of Public Health, and they take all the data, the local data, the number of deaths, the number of new cases, and they correlate all that, and then they give that to the CDC. That it works through that channel.
Okay. So let's see. Here's a question from your colleague Mark Huffman. Do you see a role for occupational health offices to fund or perform serology studies to understand which healthcare workers are safest to be on the front lines for clinical care?
That's a great thing. As more and more healthcare workers get infected, we need to have an approved serology test to find out who has had it. Probably a lot of people have had it and don't even know it because 81% or 85% have very minor symptoms, and so those people are likely to have immunity, and they should maybe go into the front line. That's a great idea.
Okay. We have a question from some medical students who want to know, I'm a medical student, I want to get involved, I want to help, I also don't want to get in the way or burden the system. What can I do?
There's, I think, a lot of stuff they could do. That's really got to be coordinated through the hospital people and the Division of Infectious Disease, which is actually coordinating all the treatment and care and the exposed people. I know some of the medical schools have the students very much involved, particularly in New York. And the same thing is going to happen here, most likely. So I can't give you the exact thing, but I think you could talk with Gary Noskin at the hospital level to see where that can start, because he's in both the infectious disease division and as a hospital officer.
Great, thanks. There's a question about Chicago. So looking at your slide 23 that shows a peak estimate at May to June, it looks like we are not going to have enough ICU or hospital beds in Chicago. Is that right? Is there time to prepare, close down hospitals, turning corporate buildings into temporary hospitals, et cetera, or are we doomed here?
I think it depends how we behave. If we can blunt the curve a little more, we can absorb some of those patients. I know that not only Northwestern, but other hospitals in the state and the governor's office are negotiating with hotels to either take them over completely and make them like coronavirus hospitals. I know in Boston that 2 sort of abandoned hospitals, Kearney Hospital and Baptist Hospital, I think, are going to be reactivated and made into coronavirus hospitals. I know in New York, Governor Cuomo has taken over the Javits Center and is going to make that several hospitals. Don't know exactly what that means, but maybe there will be an ICU part and a regular part. And so every state is kind of handling it a little different way. I know in Seattle, they bought an Econo Lodge and put some of the patients down there. So I know those, the hospitals are thinking pretty quick because they see these numbers doubling. And we don't know, you know, that slide, don't forget, that's a model, and the model is only as good as the numbers you put into it. And, you know, if this shelter in place thing works, you know, maybe that whole thing will blunt down. That's what we're hoping anyway. But if it gets lifted up too soon, or it's not enforced strictly enough, it won't work. And then we're, you know, the whole thing will be basically kind of a hospital implosion, you know, for many months to come.
When and how should we begin to know whether shelter in place is working?
That's a really good question, and it's actually pretty easy because what you'll do, since we're following the numbers so closely, as soon as those number of new cases really starts to level out and then starts to go down, we're going in the right direction. So that's this R factor. You know, the R factor is how many people an infected person infects. So as soon as we can get that less than 1, the whole disease kind of burns out. That's what has to be done. So we can follow that. That's pretty easy to follow. Death rate is a much cruder one, but that's the first thing that started going down in Italy. Hopefully that'll hold up.
Interesting. So a number of people are getting really concerned about what you've shared with us here about the fact that we absolutely have to have coordination at the national level to get traction here. And they're concerned about, in particular, the news, the president's press conference last night in which there was a suggestion that we were perhaps going to start easing some of the restrictions or changing the guidance. People want to know how you think, what action the public should be taking right now. Is there any, do you know of any efforts to organize, or what would you suggest people do about this to make sure that we don't go in that direction?
Well, you know, I wasn't taking it very seriously even after the president made the announcement, because he's made so many strange announcements, and a lot of times they just get corrected the next day, or, you know, people just ignore them. However, if you watch Fox News, which is the #1 news station, cable news network, I watched it last night. I want to see where this is coming from. I normally don't watch Fox News, but I was really horrified. You know, people, what they were promoting. I mean, now I know where that is coming from now. It's coming from there. Very irresponsible. And that's why I went over on that one slide with all those 6 charts with the mortality rate and the overall death rate. Because if we lift up our guard now, that's, you know, coronavirus will become the #1 cause of deaths and completely overwhelm the system. So, you know, this group, you know, which includes bankers, not your local branch banker, but the big bankers, many government officials, no public health people, by the way. You know, some of the commentators, Fox News Channel, I mean, they are, it's a very dangerous thing what they're promoting, because they're it's going to destroy the healthcare system and kill millions of people.
And so on that point, why stop at national? Should we be thinking about more international coordination around this?
Well, you know, yeah, I mean, that would be the best thing. you know, the European countries coordinate activities to an extent. Everybody has either eliminated or cut back significantly international travel. So those are things going in the right direction. But, I mean, internationally it would be obviously best, but you know, what international authority? We have WHO will make a recommendation, okay, but not the countries don't have to. They don't have any teeth in it. You know, the United Nations, you know, they can some recommendations too, but again, where's the teeth? The teeth is going to be at the national level, and it's all going to depend on the quality and the determination of the national leader.
Very interesting. Okay, well, this is obviously you've shared a tremendous amount with us today, Rob, and we're really grateful for your candor and your tremendous expertise. And I know that I speak for all of us in saying a huge word of thanks. Thank you also to everyone for joining. This is a weekly series, so stay tuned for an announcement shortly on who the speaker will be next week. If you also have any suggestions, you can reach out to us on Twitter or email. And we'll also follow up with a survey to get your thoughts on what else we can do in this space. Rob, thanks for your tremendous work and your partnership, and look forward to next steps together through Buffett and the Institute for Global Health working together. Thank you.
Thank you for inviting me.
Thanks.